Okay, let's start with the topic which most of the women love to hear. Diba? Any reaction? Okay. Anyway, okay. Let us start. Histology of the male reproductive system. Okay. Okay. This is your review of our anatomy of the male reproductive system. Okay. So you would see there the first we start from the down, no? You have there your testis. Okay. It is covered, it is carried by the scrotum. And then you have your epididymis, okay, and then your testes. Later on, you would see the other parts, no? Okay, you have there your the penis, okay, and then you have the different ducts, okay, and then going into passing through the layer, the pubis, and then going down into your down again, and then you will have your parts, the glands, you have your seminal vesicle, of course, you have your bulbourethral gland, you have your bladder there, you see you have your, okay, the other parts, we'll go back to it individually later on. So you've taken this in your anatomy, no? So are you through with reproductive system in anatomy? Elacion? Elacion, can you hear me now? Elacion?
Hello, Doc.
Yeah, you have
Tapos na
taken,
po.
okay, it's done already. So I will be going directly into the histology. Okay, I'll proceed. Okay, the male reproductive system will be composed of your testes, your genital ducts, where the sperm would pass. You have your accessory glands, which would contribute to the entire seminal fluid. Okay, and the respective functions. Your penis, very important, no? So how could you pass your sperm to your loved one if you don't have that very important penis? Yes? Alfred, there you are, Elisha. I see you now. Okay. The primary functions of your male reproductive system would be, of course, production of sperm, okay? Synthesis of androgens. Okay, so let's see a clearer picture of your testis. You have here your connective tissue, okay? Tunica albuginea, okay? And then you have here the testis separated contained in the lobules, you have your connective tissue, you have your, the lobules, you have your retitestis, within the mediastinum, and then you have your duct, okay, the duct full, or the ductus efferentis, ductuli efferentes, the term. Testes. These testes are paired ovoid organs, lie within the scrotum. So, gentlemen, you check your testes if you have a pair of testes, okay? And what do you observe in your testes? In your testes, let me see. The gentleman, Hidalgo. Is it on the same level?
No po, Dok. Hindi po, Dok.
Okay. So, which is higher in your case? Near the abdomen?
Left siguro, Dok.
What?
Left.
Why siguro? You're sure of it? Okay. Very important, because ladies, if you have a loved one, if you only, you can only feel one scrotum, okay, one testis, then you have a problem there, no? Okay, we'll touch it later on. It is covered by a thick, dense connective tissue capsule called tunica albuginea. Okay, so take note that this part may be asked in the practical. Tunica albuginea, thick, dense connective tissue capsule. We'll be going slowly because I'm sure we'll finish this on time. And then you have your what you call also the mediastinum testis. As you see, your retitestis is still within the mediastinum. And then you have your tunica vasculosa. It's the inner part. This is loose connective tissue. So albuginea is thicker, and then vasculosa is the inner part. It's a loose connective tissue. Tunica albuginea, dense connective tissue. Again, it's your testis, you have your tunica albuginea, okay, all your seminiferous tubules within, okay, you have your connective, okay, tissue, septum, because your testis divided into lobules, so you have these areas where you have the septum between tubules. And then this compound tubular glands serving both exocrine and endocrine functions. So your testes have both exocrine and endocrine functions. The exocrine function is the formation of the mature male germ cells, spermatozoa. The endocrine function is the production of the male sex hormone, which is the testosterone. Okay, the testes are ovoid glands, approximately 4.5 centimeters in length, and are covered by a thick capsule that is your tunica albuginea. And then the inner part that covers it would be your tunica vasculosa. It is loose connective tissue. Okay, testosterone. Okay, the functions of your hormone testosterone for spermatogenesis. Also for sexual differentiation and control of gonadotropin secretion. These are the three functions of testosterone. The hydrotestosterone acts on organs and tissues of the body during puberty and adulthood. The hydrotestosterone acts on organs and tissues of the body during puberty and adulthood. Testes develop retroperitoneally in the dorsal wall of the embryonic abdominal cavity. Dorsal wall of the embryonic abdominal cavity. Migration from the abdominal cavity. Each testis carries with it a serosac. You call this tunica vaginalis, derived from peritoneum. Okay, as it migrates down from the abdominal cavity. Okay, it carries the tunica vaginalis, which is derived from your abdominal peritoneum. Failure of the descent into the scrotum would be cryptorchidism. So if you have boyfriends, try to, try to what you call that, feel or see if your boyfriends have two testes. Otherwise, you may have a problem not having a child because the other testis is abnormal, and you are not sure of the other one, which may be functional or not. Okay, so let's look in the histological features of your testis. Okay, with your seminiferous tubules. Okay, again, your tunica albuginea. Okay, from outer, outer. Tunica vasculosa, there you are, which is coming from the peritoneum, okay, downwards, okay. And this testis go down. And then you have your, of course, your seminiferous tubules, where you will find the cells, okay, important in the development, in the spermatogenesis. Each lobule of testis consists of 1 to 4 seminiferous tubules and the connective tissue stroma, which you call the interstitial tissue containing Leydig cells. Leydig cells are very important, no? You know later on. Seminiferous tubules, 1 to 4 seminiferous tubule, and a connective tissue stroma, which you call interstitial tissue containing Leydig cells. Seminiferous tubules, interstitial tissue with Leydig cells, as pointed by the arrow, okay? Or interstitial cells. So when we say interstitial cells, we are referring to the Leydig cells. It is large, polygonal, okay, eosinophilic cells, meaning to say in the staining procedure of H&E, it is pinkish, okay? Large, polygonal, eosinophilic cells producing your androgens. Okay. There you are. Okay. Seminiferous tubule. Okay, again, we see now the layer of the seminiferous tubule. You have your epithelium, take the arrow. So we will start from the base down, no? Okay. So there you are. You have spermatogonia, okay, or spermatogonium if it is only one, and this is the most immature of all our developing sperm cells. So you have your type A dark spermatogonium, and then you have there the type B pale spermatogonium. Okay, there you are. The classification of being pale or dark would mean, of course, your cytoplasm. No? Okay. It's dark or pale. Okay, the mucosa, the lining mucosa, of course, your stratified epithelium. Stratified epithelium. There are two basic cell types in the stratified epithelium. Okay. Now you have here spermatogenic cells. This would develop into your spermatozoa later on. And you have there the sertolized cells or sustentacular cells. The sertolized cells or sustentacular cells are big, no? Because they are the ones that give nutrition to the developing cells of spermatogonium, and then there would be spermatocyte and up to early spermatid and late spermatid. Okay, so they supply the nutrition of your cells, developing cells. This is very important. You would know that the development of your sperm from the base, it is still, of course, they are the most immature. They're called your spermatogonium. Okay, gonium. Okay, as they grow, as they not flourish, you will have your primary spermatocyte. By the way, the secondary spermatocyte is not seen in this time because it's so fast. It's so fast that they become spermatid, early spermatid. So we cannot see secondary spermatocyte, but there is only in different staining procedure you do not see. Rarely the book can find. No? Okay, so there you are, important feature of sertolized cell. Take note that the sertolized cell would start from the base, okay, where you have your spermatogonium, down to the near to the lumen where you have your spermatids. They cover and nourish all the developing cells. Okay, again, there's another view. Spermatogenic cells. There you are, spermatogonium. This is illustration because you can see here your secondary spermatocyte. Spermatogonium, primary spermatocyte, secondary spermatocyte, early spermatids, and then the late spermatid, and then you will have your sperm. As you would see there, okay, you see the already the body, the later part, and there is already your, what do you call this, beginning tail, but it's not yet complete. You don't have the middle part or the neck and all. Spermatogonia, primary spermatocyte, secondary spermatocyte, spermatid, early and late, and then now the fully developed sperm cell. Stages. The Sertoli cells, they are columnar cells. There you are, as pointed, columnar cells. Okay, another view. Okay, you have your Sertoli cells. Okay, you see the Sertoli cells there, class. Look carefully. I don't know what's wrong with my arrow. I cannot pinpoint. Okay. Okay, you have your, from the base, you would see, okay, there is the endothelial cells. Okay. And then you have the myoid cells. And then you will have the basal compartment area. So you have actually two areas. Okay. Now, from the spermatogonium down to the abdominal compartment. Okay, that would be from the spermatogonium down to the abdominal compartment, wherein you would see already the late spermatids. Okay, you will see here the capillaries, luminocapillary at the basal portion. You have the endothelial cells, the myoid cells, and then the rest of the developing. Okay, the Sertoli cells surround this. Okay, you would see there the Sertoli cells. They are as if they are floating, in the Sertoli cell. But of course not. It's an illustration, so you will have a better understanding. Okay, so the supporting cells, the Sertoli cell to Sertoli cell junctional complex. Okay, this is, you see the Sertoli cell, no? There you are. And then Sertoli cell to Sertoli cell junctional complex. So this area. Shit. One here, one, and this one, yeah. Ano ko point kasi nag-action ang culture. This one, and it's not. Here is the Sertoli cell, no? Okay, Sertoli cell. Anyway, it's labeled there, no? This is the Sertoli cell to Sertoli cell junctional complex. This area, this one here, Sertoli cell, and this one, these are the Sertoli cell junctional complex. You have your sonnular adherence. Okay, you have learned what is sonnular adherence, that keep together the different cells. Okay, sonnular adherence. The site, this is also the site of the blood testis barrier. This is the site of the blood testis barrier. Divides the seminiferous tubules into the basal and luminal compartments. Okay, luminal, the lumen, where you have your different developed cells later on. Provides nourishment to the developing spermatogenic cells. Yes, your Sertoli cell. That's why it's so big, no? It comprises all the range, the area where you have developing sperm cells. Provides nourishment to the developing spermatogenic cells. So therefore, the functions of the Sertoli cells would be to support, protect, and give nutrition to the developing spermatogenic cells. Another is exocrine function, secrete fluid used for sperm transport, because the sperm cannot travel even if they have your tail, because if there is no fluid, that would be the means by which they can move. The endocrine secretion of your inhibin. This is a feedback loop into anterior pituitary to suppress synthesis and release of FSH. Okay. Okay. Mullerian inhibiting substance. Okay. And of course, the function, you have another function for the phagocytosis. These are the different functions of your Sertoli cells. Okay, so this is in your book. You can just follow this up. It's Spermatogenesis. Okay, you have your type A. We talk about type A. Dark spermatogonia developing into two. Just take one. No? There will be type A, pale spermatogonia. Of course, the pale, it's daughter cells too. There will be after the maturation. Type A, you have two again, and then again that would always be the ratio. And then we go to the primary spermatocytes. They will develop into two secondary spermatocytes. Okay. Again, you will have your early spermatids and then the late spermatids. And then you will have your, as the spermatids develop, the residual bodies separate, and you will have now the sperm cell, the mature, no? Spermatozoa.
Excuse me po, Doc.
Yes.
Doc, are you moving your slide po? We are still, your slide po in our screen is still in spermatogenic. Okay na po pala, Doc.
Okay na, medyo late lang, no? Yes.
Yes po, Doc. Medyo late po yung sa screen.
Okay. Oh yeah, that's right. Sige, I'll give time, about siguro mga 10 seconds, no? Okay, so there you are. It's, anyway, it is in the book, okay? Just to tell you to know this, because later on when you study it, it's important you will know the X, Y, okay? And the N. Okay. Medyo delay ang process by which spermatogonia develop is into sperm, okay? Approximately 74 days. So from the immature, most immature, to become spermatocyte, the development would be 74 days. So we have first a spermatogonial phase from the word spermatogonia, no? The most immature. Stem cells divide to replace themselves and provide a population of committed spermatogonia. So not all there would be developing, only the committed spermatogonia, committed to develop. Okay. Okay. And then you have the spermatocyte phase. Primary spermatocytes undergo meiosis, okay, to reduce both the chromosome and amount of DNA, okay, the number. Spermatocyte phase. And then the spermatid phase. This is now the final phase, which is your spermiogenesis. Spermatid phase. Okay. So this is the better view that you would be studying, wherein we have only one, okay, cell developing into four, okay, last. Primordial germ cells in the gonad, week 4, okay, remain dormant until puberty. So this will be the end now of your being a child, rather young teenager. When you have already, when you start already your puberty, now this is your stage in which you become attracted to males, at least. At puberty, differentiate into spermatogonia. Okay, so the differentiation of the spermatogonium, okay, to primary spermatocytes at puberty, wherein you call this meiosis 1, okay? And then 2 to secondary spermatocytes, you call this meiosis 2, wherein you will have now 4 spermatids. Take a look at the illustration. No? There you are. And then you have these early spermatids 4 and the late spermatids 4. And then there is now your maturation. Okay. Okay. So mature sperm cells. Primordial cells remain dormant until puberty. Maturation of a sperm begins at puberty. Maturation, take note of the word. One primary spermatocyte gives rise to 4 daughter cells. All 4 develop into mature gametes. So, walang nasasayang, no? 4 gametes. Spermatogenic cells. Spermatogonia, stem cell, diploid chromosomes. Diploid, or you will answer 46 chromosomes or 44 XY. Okay, take note. When you include the XY, chromosomes will be only 44. 44 XY. If you do not use the XY, male or female, you know that already, then you use 46 chromosomes. Both are correct. Primary spermatocyte 44XY, also the same, 46 chromosomes. Okay. Secondary spermatocyte, this will be now 22X or 22Y or haploid. Do not answer 22X and 22Y. It's either X or Y with 22. Or you just call it haploid, no? The chromosomes. The spermatid, the same, okay? 22X or 22Y or haploid. Sperm cell, the same. It's now you're mature. You know that it is haploid because when you have your egg of the female, that will complete your human chromosome number. Okay, now let's just see. Review the cells. You will have there your Leydig cells. Okay. You have there your Sertoli cells. Okay, the big one. Okay. And then pale, yeah, right? Big cells. And then the spermatogonia or this spermatogonia, these are the immature cells. Okay, they are found in the basal layer of the tubules of the testis. There you are, lining. It is dark, the nucleus is dark, dark stain. Okay, and you know that they are spermatids, they are smaller now. Okay, the nucleus is like, fills the entire cell, spermatids. Okay. Take note that when it is primary spermatocytes, okay, coming from the spermatogonia to become a primary spermatocyte, it would be a bigger, but the nucleus is not as solid as it is. Okay. Here you are. Those are the things that you would have to remember when the description is given. That is a palay, no? Looks like a palay. Okay, then we are describing your spermatid. Okay, your late spermatid. Okay, when it is still rounded, that is spermatid, early spermatid. Okay, so please study this well. You might be confused when questions are given. Okay. Spermatids to sperm cells. That is what you call spermiogenesis. The changes that occur from spermatids to become the sperm cell. First, the formation of acrosome. And then the condensation of the nucleus. Take note that when it is spermatid, the nucleus is not so dense, no? Hindi pa buong buo. Condensation of the nucleus, and then formation of neck, middle piece, and tail. Do not be confused of the neck and the middle piece. Okay? Do not say the neck to include the middle piece, nor you say the middle piece to include your neck. Of course, the last is your tail. And then, of course, the shedding of the cytoplasm. So, ready na siya to do battle, to, travel all through that kilometers of ducts to reach the egg waiting in your loved one. Okay, so there you are. Formation of acrosome, condensation of nucleus, formation of neck, middle piece, and tail, and the shedding of the cytoplasm. Okay, before you can call it ready to do battle, to find his egg. Okay. Okay, there you are, the development. Okay. So acrosomal granule. Okay, you have your Golgi complex, of mitochondrion, centrals, all the things that you need for development. And then you have the acrosomal vesicle. Okay, you find the nucleus. Okay, getting smaller. Okay, still rounded. And there you are. When you have now the development of from the acrosomal vesicle to the acrosomal cup. Take note. Okay, take note that the vesicle is not yet attached to your nucleus. In the acrosomal cup, it is already attached. Na sombrero na, kumbaga. Okay, and then you have there, finally, your acrosome. Acrosomal granule, becoming acrosomal vesicle, becoming acrosomal cup, and acrosome. Okay, then you will have your middle piece. There you are. Okay. Of course, the cytoplasm and the rest are the residual bodies. Okay. And so the final missile that you would be producing would be your 5 microns acrosome, your neck. Okay. You have your middle piece where you have your mitochondria. You have your principal piece, okay? And then you have your end piece. 5 microns, 5 microns, 50 microns, and 5 microns end piece. Please take note of this. Okay. Sperm cell now. You're ready, no? You have your acrosome, the head, the nucleus covered by the acrosome. And then you have the neck, you have the middle piece of the tail, okay? And then the end piece of the tail. You have the principal piece of tail that gives the movement, okay? More. The normal fertile male has around 100 million sperm cells per milliliter of semen. Okay, milyonaryo tayo, bilyonaryo, no? Single ejaculation amounts to 2.5 to 3.5 ml. Okay, so if you ejaculate 3 ml times 100 million per ml, you will have 300 million per ejaculation at 3 ml. So if 3 times to ejaculate, okay, who ejaculates more than 3 times? Oh, not every day naman, but, you know, sometimes. Anyone? Oh, male dito. Sino ba ang male dito? Si Hallelujah. Okay. Hallelujah. Hallelujah. How many times normally you ejaculate? Hallelujah.
One time la, Doc.
Once daily?
Yes, Doc. Every
Yes.
daily po, Doc.
Louder.
Daily po,
Once?
Doc. Once.
Daily before taking a bath. Is that so? Don't worry, many do so, no? Okay. Okay. Sige. Oh, that's okay. You have so much reserve, no? Why don't you make use of that? Okay. Okay. Anyway, do not believe all that we say here. Okay. When I ask questions, I know you are not answering me the truth. Okay. Okay. Sige. Let's proceed. I hope you understand, and I'm taking this very slowly so that there will be no need for you to review. Diba? It goes into your mind easily when all these things are all these things. Okay, anyway. Sterile male. Ayan, yung mga sterile yan. Isa na yon, yung reproductive, no? Ito naman, okay? If you are normal, you're not cryptorchid male, then if you release only less than 20 million sperm cell per ml of semen, yeah, you are called already sterile, no, male. Kaya yung mga matagal, 6 months ng married, gusto manganak, pero hindi nakakabuo. For male, you start thinking after 6 months, no? Bakit kaya? Sa position ba yun? Or sa timing? Okay, whatever. But have a count of your sperm cell. Anyway, madali yun. Very easy. Okay? Para sigurado ka. Huwag ka na lang magpahalata sa misis mo na low sperm, sterile male ka. You know, anyway. Factors affecting spermatogenesis. So, your development of your sperm from spermatogonia to a spermatocyte, spermatid to sperm cell, mature sperm cell. Itong mga factors, okay? Dietary deficiencies, okay? Dietary deficiencies, meaning to say, you have to have the complete, no? Okay, no, not so good, no? Alcoholism and all that. Anyway, dietary factors, dietary deficiencies. When you have had infections, okay, infections. But these are not, of course, absolute, depending on the, when all of these factors are there, you know, in you, then you have a greater chance of being sterile, or there will be problem in the production of mature sperm cells. So you have infections, elevated testicular temperature, okay? So it's important that, especially those who work, no, in environments wherein you have high temperature, tendency niyan, you will not have a developed normal development of your spermatocyte, sperm cells. Okay, and of course, important temperature is to maintain at least 34 degrees centigrade. Okay, so that's why, di ba, pag medyo giniginaw tayo, when you put your hands in your front, okay, between your legs, mainit, medyo mainit kasi it's 34 degrees centigrade. Okay, huwag naman sobrang taas, 41. Okay, because that will already be detrimental to your sperm development. Then steroid hormones, taking steroid hormones, okay, would be a problem. Okay, but of course, if you need, then you have to take it as part of your medication, perhaps. Toxic agents. Toxic agents. Let me ask. I'm thinking because I might ask a woman. Sino mga lalaki dito? Aporilio, yes. Aporilio, what are the toxic agents that may, you know, give problems to the development or to the process of spermatogenesis? Aporilio?
Agents.
What are the toxic agents?
Carcinogens, Doc.
What? I cannot understand.
All types of carcinogens, Doc.
Carcinogens. Okay ka naman sumagot, ano? Walang lusot. Lahat na lang. No, in your daily, living up, enjoying the world, what are the things that when you take most of the time, then it, makes your body not so healthy or quite, problematic. Cancer, poor. So what are the other toxic agents? Do you drink? Aporillo, do you drink? I mean, wine? What they call this, alcohol?
Yes, Doc. Occasionally po.
Oh, but not too much.
Yes,
Okay.
Doc. Not too much because it also degrades your procreation.
Mukhang may hindi nag-agree sa'yo. Anyway, yeah, toxic. Anything that is not, not good to the body. Those are toxic agents. Okay. So there you are. It might be a substance. It might be an ordinary food, but then you're taking it too much, then it becomes toxic. Anyway, the toxins of infections are already there, so this affects your spermatogenesis. Radiation, okay? So anyway, even if you have your X-ray twice a year, that would be not in excess, no, but radiation, when you need this radiation study, then perhaps you will get. So there you are. Now, let's go to the hormonal regulation of male reproductive system. Hormonal, okay? So, your anterior pituitary gland or adenohypophysis. Dr. Lasaka has lectured this already to you. The hormones, the anterior.
Yes, Doc.
Okay, so this would be a lot easier now. Okay. FSH, okay, stimulates spermatogenesis, follicular stimulating hormone. Look at the diagram, no? Okay, so you would know that there is a feedback mechanism. If it is already enough, okay, the body itself knows to have it, the feedback to stop it. That's why you have your arrows there, Leydig cells, the FSH, luteinizing hormone, okay? And then you have your testosterone, and then you have your different, yes, you have your inhibin. Okay, there you are. Please study this diagram. LH stimulates Leydig cells to secrete testosterone. Okay. So the other one stimulates spermatogenesis. The other one stimulates Leydig cells to secrete testosterone. Okay, it's clear there in our diagram. Please study this. Okay, Epididymis or Epididymis. Okay, sabi nila, the correct pronunciation is Epididymis. But because you are literally dead when this epididymis functions. Of course, it's not true, no? You need to say you are undergoing sex. No, okay, because the cells there that are stored will now be lots, millions of them will be lots. Let's start. Okay, crescent. No, it's a crescent shaped structure. Beautiful shape. Okay, of course, divided into the head. You have there. Okay, the head, the body, and the tail. The tail starts from the tail of the end of the tail of the epididymis, and that becomes now the what you call the ductus, long ductus. Again, I'll just point out to you, do not forget your straight tubules in your testis, your retitestis, no? Okay. And then the parent ductules, and then the epididymis, of course, the head of the epididymis, the parent ductules, and then the tail of the epididymis now going into what you have this, okay, becoming the ductus deferens. Epididymis is the site of storage and maturation of sperm cell. Okay, site of storage and maturation of sperm cell. So that's why, hallelujah, even if you do your thing every day, there will always be sperm cell, because we have millions there in your epididymis stored. Okay, so some are matured, some are not. So, but this, but not yet mature, they are not yet released. Okay. Okay, the epididymis is about 4 to 5 meters in length. Okay, dami din yan, no? Siyempre, it also makes space, it expands when you have more sperm cells there. Okay, so let's look at these. You see there again, you know the it is lined, your epithelium is pseudostratified. This is your epididymis, pseudostratified epithelium. Okay, pseudostratified columnar epithelium with stereocilia. Okay, stereocilia. So you would know the nucleus, they are not on the same level, so they are pseudo-stratified. You will think that there are so many cells in there, but actually one touching the basement up to the end, no? The space, the lumen, epithelium, columnar with stereocilia. If you answer without stereocilia, then your answer would be wrong. If I ask you the lining of your epididymis, okay, there you are, epithelium. Pseudostratified epithelium columnar with stereocilia. So you have there your principal cell and your basal cell. So that's why you look at it as if you have 2 layers, because of the location of the principal cell and the basal cell. Okay. Okay, there you are. Spermatozoa undergo additional physiological maturation. So you call this physiological maturation occurring in the epididymis capacitation. Okay, the capacity to travel and the capacity to fertilize the ovum or the egg. No? Okay, this occurs in your epididymis. Maturation, physiological maturation, because even if they are still in the testes, some are already mature, but they are not physiologically mature, just like a human being. No, all the parts of the body are okay, but hindi pa sila, they have not reached puberty. Therefore, they have to go physiological maturation. And so you have all these things that occur to the male to become, ready for the what you call capacitation, become capable of having a child for her loved one, no? Pwede na. Okay, so physiological maturation occur in this organ. Okay, so epididymis, just take a clear picture of the part. You will have this smooth muscle cell, of course, lining. Okay, and then the spermatozoa, yung laman, doon makikita mo, epididymis. And then you will have your principal cells. There you are. And then the lining epithelium, take note. The lining epithelium, di ba? You know, mucosa. You have the lining epithelium. You have the lamina propria. Di ba? Those are parts. And then, of course, you have your mucosa. Okay. Pseudostratified columnar with stereocilia. Okay. And that nucleus pointed is the principal cell, and then the basal cells. That's self-descriptive. Basal cells, that's a base. Okay. All right. That gives you now your pseudostratified columnar. So this is epididymis under high power objective. Okay, so vas deferens. So as you know, as the sperm cell travel, you will have your vas deferens. Okay, so this is descriptive anyway. Okay, there you are. Okay, you will see, you look at the lower portion, no? Picture. You will see you have the lumen, okay? And then you will see there the lamina propria. There you are, okay? Okay, the smooth, okay? Cell, and then the smooth middle, okay? Well, you have your longitudinal, okay? You have two smooth muscle cells, longitudinal, and you have the middle circular, okay? The upper picture, okay? And then the one in the middle also, lumen. But take note of the first one because that is quite clear. No, L is for lumen, okay? Yun ang dadaanan ng sperm. And then you have the smooth muscle, okay? Longitudinal, and then you have another smooth muscle, your circular, and then you have another smooth muscle, okay, longitudinal, okay. There's three areas to have your muscles, but then two kinds of muscles. Unlike in your stomach, you have the different layers. equal, diba? Vas deferens. Direct continuation of the tail of the epididymis. Okay. Mucosa is pseudostratified columnar epithelium, the same as your epididymis, except there are no stereocilia, okay, in the endothelium. Pseudostratified columnar epithelium. Okay, so from now on, all the lining will be pseudostratified columnar epithelium until we reach the penis, no? Where there would be changes. Okay. The tunica muscularis, as I've said, you have the inner longitudinal. Okay, that's the one that is near the lumen in the picture. Okay. Okay, inner longitudinal. And then you have your middle circular, SMC, in the first picture. And then you have your, again, inner longitude, you have your longitudinal, no? Another, so you have your longitudinal near the lumen and out, no? Near, at the end, and then you have your circular. Okay, so you have inner longitudinal, middle circular, outer longitudinal. You have now, our third layer would be, you have your tunica adventitia, okay, wherein you find your blood vessels. Okay, there you are, different blood vessels and arteries. Okay, tunica adventitia. Okay, so review of our vas deferens, mucosa lined by pseudostratified columnar epithelium, no stereocilia. Submucosa, you do not find submucosa in the vas deferens. Tunica muscularis, the third layer, you have your inner longitudinal smooth muscle. You have middle circular smooth muscle, outer longitudinal smooth muscle. And then you have your tunica adventitia, the fourth layer, you have loose, okay, connective tissue with fibroblasts, elastic and collagenous fibers, blood vessels, and lymphatic vessels, similar to other tunica adventitia. Okay, so please understand this. Vas deferens again. Okay, so you see there the outer longitudinal muscle. You have the middle circular muscle. You have your inner longitudinal muscle, and then the lamina propria. Lamina propria. There you are. The lining epithelium is pseudostratified columnar epithelium. Okay, of course, the one pointed by the dark, okay, that's the lumen. Okay. Seminal vesicle. Okay. In the low power, you would see the first one picture, and the higher this one. Now, there is a specific, okay, they call this specific description for this for the seminal vesicle. Okay, the seminal vesicle, anatomically, it is paired, elongated, and highly folded tubular glands, highly folded. It is about 15 centimeters in length. Again, the lining epithelium is pseudo-stratified columnar, as I said to you, from vas deferens down here, okay, seminal vesicle, pseudo-stratified columnar epithelium. The mucosa is thrown away into numerous primary, secondary, and tertiary folds that increase the secretory surface area. So you have here this, okay. So from here, this is the primary, this is the secondary, and this is the tertiary folds. Okay, the lower portion, those are the one that we call folds. Okay, that increase the secretory surface area. So what is the secretion of your seminal vesicle? Secretes a whitish yellow viscous material containing fructose, fibrinogen, and prostaglandins. Your semen, gentlemen, 70% of your semen is produced by the seminal vesicle. Easy to stick it in your mind. Seminal vesicle gives 70%. Okay. Of course, you have taken this already in your physiology. Fructose, sugar, energy. Okay, fibrinogen. Okay, that is protein, prostaglandin for your function and the inflammatory, you know? And they have a specific function, and they compose seminal vesicle 70% of your semen. Okay, again, the seminal vesicle. You see there, you have your lining epithelium, pseudo-stratified columnar epithelium. Okay, and then you will have your inner circular. You have your outer longitudinal, and then there you are, your tunica muscularis. So mucosa, you have here the lining epithelium, you have there the lamina propria, and then you have your inner circular, outer longitudinal. There is no middle, okay? No smooth muscle middle, no? It's only inner and the outer longitudinal. And then you have your tunica muscularis. And the last, of course, is tunica adventitia. Okay, so take note of that. No, there is no middle, smooth muscle. Prostate gland. Oh, how I love this organ that gives me my illness, no? Prostate gland. Largest accessory gland, weighing about 20 grams. Consists of 30 to 50 tubulo-alveolar glands. Okay? Tubulo-alveolar glands. Again, The lining epithelium is pseudostratified columnar epithelium. So lahat yun, no? Except the first one, which is with stereocilia. Secretes prostatic acid phosphatase and citric acid. Prostate gland. They produce your calcified secretions you call prostatic concretions or corpora amylacea. Take note, corpora amylacea, not the one in the brain. No? Okay. Okay, here your prostate gland. You have your stroma. There you are. And then prostatic concretions. There you are. Corpora amylaceas. Don't confuse this with your thyroid. Okay. And then you have your tubuloalveolar gland. These are the features that you should know especially in the practical, no? That prostatic concretion, corpora amylacea might be given. There are 3 zones of the prostate gland. You have the transition zone. 5% of the gland's volume contains the mucosal glands emptying directly and surrounds the prostatic urethra. So this gives you urination difficulty if this is involved. No? Central zone, 25%, contains the submucosal glands. And then your peripheral zone, 70%. Now, this is the finding in my case. Okay, most common location of inflammation and cancer. Okay, so in my case, it is cancer. Thank God, I'm still alive. Okay, must know, therefore, largest accessory gland is your prostate. It is an inverted pyramid about size of a walnut. Okay, the base is located inferior to the neck of the bladder. Okay, that's why it gives rise to problems in your, especially the old people. No, anyway, it starts from 45 and above. No, there might be already these changes because of the prostate gland affectation. The apex rests on the sphincter urethra. Okay, sphincter urethra, the apex. So if it is involved, there will be problem in the micturition. The prostate-specific antigen blood test and a digital rectal examination, DRE, is done to evaluate gland size and presence of nodularity. So the posterior area is being tested. Once you have there an enlargement or presence of nodularity, basically you have to go further analysis. Okay, and that would be most probably adeno. Okay, or the next, the just hypertrophy only. Okay, so when you make this examination, benign prostatic hyperplasia, okay, or hypertrophy, commonly occurs in the periurethral transition zone of the prostate and may result in obstruction of prostatic urethra, impeding the urinary flow and result in incomplete emptying of the bladder. There is difficulty initiating urination and increased need to urinate. So several times you have to wake up in order to urinate. in the evening 4 or 5 times. Now this is my case, adenocarcinoma. Okay. Commonly developed in the peripheral part of the prostate, in the main pancreatic glands. Kaya when you do the examination, okay, you would feel it. The urine flow may be altered and patients may pass blood in the urine. Okay. I did not experience that blood in the urine. Elevated blood levels of prostatic acid phosphatase and the prostate specific antigen. Okay, so when I had my examination, initial examination of my prostate specific antigen, it is a record-breaking result. You know why? The answer of the machine cannot be counted anymore. So, okay, so they cannot count anymore my PSA. That's why after 1 week, I have to be operated. Thank God I'm still alive. Okay, class, don't forget your adenocarcinoma for sure. It will appear in your examination. Your benign prostatic hyperplasia, your different glands as to their functions and secretions. Okay, and of course, the lining epithelium, you have only 2 things to think, no? You have your, okay, the one with the stereocilia, the other with, okay, without, no? You have the transitional, okay, and most of these glands. Okay. Okay, now you will now have the bulbourethral gland or the Cowper's gland, where pea-sized glands, malit lang. Again, it is tubuloalveolar gland. Secretion is alkali, which neutralizes acid urine. Okay, para pagdaan doon ng sperm, hindi masisira. Okay. There would be it on the alkali or normal, no? Not because when the urine passes there, you have your acidic, okay, part. So it is now the secretion of the Cowper's gland or the bulbourethral glands that neutralizes that area. Semen contains fluids and sperm from the testes and secretory products from the epididymis, vas deferens, prostate, seminal vesicles, and bulbourethral glands. Okay, from the epididymis. Then the pathway, the vas deferens, and the prostate, seminal vesicles, and bulbourethral glands. Okay, again, 70% of your semen comes from your what? Seminal vesicles. Alkaline, your semen, as it passes through your urethra, okay, it is alkaline to neutralize the acid environment of your vagina. Otherwise, all your sperm cells would die. Okay. Average ejaculate has a volume of about 3 ml and normally contains up to 100 million sperm per ml. So 100 million, okay, per ml. If you ejaculate 3 ml, then you will have 300 million. But sometimes, you know, when I was a student, I was the subject in the study of the semen, okay, counting and all that. And of course, the volume, most of my, I think our professor, Dr. Rodil, Secretary of Medicine, FEU, was surprised that I think I have almost 5 ml when had that had that ejaculation. And anyway, that's a pass. So we have, and then our doctor, the good doctor, asked me, Casimiro, you have so many, your millions of, well, sabi ko. Anyway, how many are you in the family? Sir, we are the siblings, we are total of 13. So we had a class at a laugh because that's the reason why you have also. Okay, so the semen, there you are. Penis, we go now the last part. Penis is formed primarily of 3 cylindrical masses of erectile tissue. You know that? You have the paired corpora cavernosa and the ventrally placed corpus spongiosum. Spongiosum, malambot, diba? Spongy. Corpus spongiosum, where you find the urethra. A dense fibroelastic tissue, the tunica albuginea. Okay, again, here you have your tunica albuginea. Take note of your testes. Okay, binds the 3 together and forms a capsule around it. So scrotum, this is now continuation of the tunica albuginea in your scrotum. Binds the 3 together and forms a capsule around it. Okay, now the lining epithelium, take note of the urethra, prostatic urethra, uroepithelium or transitional. The membranous urethra is stratified or pseudo-stratified columnar, okay? And the penile or the spongy urethra is stratified, okay? The same as the membranous urethra, is stratified or pseudo-stratified columnar, except at the fossa navicularis. In the fossa navicularis, the lining epithelium is stratified squamous. Okay, so don't forget that. Penile urethra or spongy, stratified or pseudo-stratified columnar, except at fossa navicularis, where it is stratified squamous. O kaya medyo makapal doon kasi stratified. There's no one lining only. This is stratified, no? Okay, squamous. Okay. Take note of this, please. Okay, the penile urethra, there you are. Take note of the dorsal vein and artery. There you are. You have your tunica albuginea surrounding your corpus cavernosum. Okay. And then you have your urethra, and you see it is what? Pseudo-stratified columnar epithelium. Okay. Pseudo-stratified columnar epithelium. Of course, in the fossa navicularis, it is stratified, diba? You have what do you call this? Squamous. Okay, stratified squamous. Okay, thank you, class. Okay, I hope you got the lectures clearly. I made it so slow so that you will all get a perfect score. Okay. We have our clinical pathological conference today, this
Yes,
afternoon.
Doc.
Okay. Okay, so we have still time, about how many? 15 minutes to prepare. Okay. Please study well in the next examination. Okay. Bye-bye. Please tell me the those that are absent. Okay.
Yes po, Doc.
Okay, please. Thank you. And good luck to your examination.
Thank you, Doc.
Goodbye.
Thank you, Doc.
Bye-bye.
Doc.
Thank you, Doc.
Thank you po, Doc.
Thank you, Doc.
Thank you, Doc.
Okay.
Thank you, Doc.
Bye. Yes. Bye-bye.
Bye, Doc. Thank you.